Good morning. Welcome to another session under short course in clinical epidemiology. As we have been doing a series of diagnostic accuracy studies, today we are going to look at a STAR D AI checklist where there is a diagnostic accuracy study using an artificial intelligence algorithm. So we will have Dr. Joseph Liyaskar who will be presenting a study and looking at whether the reporting has been in uh, conformance with the STAR-D AI checklist. And we also have a second part in today's session where Professor Tambu David will be handling a session on cognitive bias in diagnostics. So without further delay, I'll hand over to Dr. Joseph for the first session. Thank you, Dr. Joseph.
Thank you, sir. For today's CU presentation, I'll be using the STAR-D AI checklist for the reporting of a diagnostic accuracy study. For today's CU session, I'll be using the now I'm able to hear. For today's CU session, I'll be using the STAR-D AI checklist for the reporting of a diagnostic accuracy study. The outline of my presentation will include a brief introduction, a case scenario, and we'll be seeing whether the article that we are looking at adhere to the standard STAR-D AI guidelines for the reporting of a diagnostic accuracy study. So first, coming into the clinical scenario, we'll be looking at two different clinical scenarios. First is Mrs. A, who's a 26-year-old retrovirus negative woman who has presented to a government hospital for routine cervical cancer screening. She is asymptomatic and she denies any history of any high-risk sexual behavior. In the second scenario, we see another 40-year-old lady, Mrs. B, who's retrovirus positive with a history of high-risk sexual behavior, and she has presented with complaints of persistent discharge per vaginum for the past 3 months and unexplained weight loss. A local physician has referred her to the government hospital to get herself screened for cervical cancer. So the question for the day will be, will an AI-based cervical cancer screening test demonstrate a higher diagnostic accuracy as compared to the routine VIA test, which is visual inspection with acetic acid, which is routinely used in low-income countries for detection of cervical intraepithelial neoplasia? So just a brief introduction about cervical cancer, which is one of the commonest cancers in women, especially in low and middle income countries. And one different thing as compared to other cancers is that it can be identified in the precancerous stage, and if effectively treated, we can prevent progression to an invasive carcinoma. And these are the precancerous stages of cervical carcinoma, which include CIN1, CIN2, and CIN3, which is otherwise called as mild, moderate, and severe dysplasia and carcinoma in situ. CIN1 is otherwise called as low-grade squamous intraepithelial lesion, and CIN2 and 3 are called as high-grade squamous intraepithelial lesions. So the current guidelines, as per the WHO, involves testing of both primary HPV as well as cytology in resource-rich settings, whereas in resource-poor settings, the ideal screening test advised is a VIA, which is visual inspection with acetic acid. So the article that I have chosen for today's presentation is an article, a diagnostic accuracy study published in Lancet in January 2026, which looks at the performance of an artificial intelligence-based tool for cervical pre-cancer screening used in 5 countries in Africa. It was a prospective observational diagnostic accuracy study. So we'll be checking whether the study adhered to the standard STAR-D AI checklist for reporting of a diagnostic accuracy study. This is a modified version of the STAR-D 2015 guidelines, which adds on to artificial intelligence as well. So coming to the first question, did the study report itself as an AI-centered diagnostic accuracy study? And did it report at least one measure of accuracy? Yes, the study has reported that it is an AI-centric study and it has used an AI-based method for cervical cancer screening. And it has also reported measures of accuracy, including sensitivity, specificity, positive and negative predictive values. And did the study provide a structured summary of the study design, methods, results, and conclusions? Yes. For this, I've used the STAR-D checklist for abstracts, and this is the reported abstract in the study. They have given the identification of the study as a diagnostic accuracy study, and they have clearly mentioned the study objectives, which is to measure the sensitivity and specificity of the automated visual evaluation using AI-based technique for histologically confirmed CIN lesions. And they have told that this was a prospective study. They have clearly given the eligibility criteria for the study, and they have mentioned that participants in the study were recruited by convenience sampling. They have also described the index and the reference standard as well. The index test was the automated visual evaluation using an AI-based test, and the reference standard was a histologically confirmed CIN2 lesion. The number of participants are also clearly mentioned in the study, and they have also reported sensitivity and specificity along with its confidence intervals. In the end, they have also given a generalized interpretation of the results of the study and implications for practice. They have not mentioned any registration number or name of the registry of this particular trial. And next, coming to the scientific and clinical background and the intended use of the index test, whether it's novel or there is an established index test which is previously available. The background is that in low and middle income countries, we have very less access to HPV DNA testing, which is the ideal screening test. So these low and middle income countries usually rely on this VIA test, which has a suboptimal accuracy for screening for cervical carcinoma. Multiple studies have shown that the pooled sensitivity is only about 56%, and some studies have even reported a pooled sensitivity of even as less as 22%. So this study looks whether AI-based technology can add on and to the whether can it improve the sensitivity of the current screening test. Next, coming to the study objectives and hypothesis, the population included in the study were women in the reproductive age group between 25 to 15 years, recruited by convenient sampling. The index test was an automated visual evaluation using an AI-based software application loaded in a mobile phone. And the reference test was a gold standard, which was the histopathological cervical biopsy. The outcome they looked at in the study was sensitivity and specificity of the automated visual examination. And another outcome they looked at was the comparison of the sensitivity and specificity with the current screening test, which is the VIA. The setting of the study was the study was done in Africa, 5 different countries between March 2022 to January 2023. They also intended to do secondary analysis, which included measuring sensitivity and specificity of AVE assisted VIA, in which the index test was considered to be positive if either the AI-based test or VIA was positive, instead of either one of them being positive. They had also planned to do a tertiary analysis in which they preferred to use the reference standard as histopathology with HPV testing instead of just histopathology alone. And next, coming to the study design, whether the data collection was planned before the index test and reference test was performed. Yes, the study was a prospective test. Yes. There are some patients who did not get a cervical biopsy in the end, that I'll be coming to in the coming slides. The study was a prospective study, and whether they had got a formal approval from the ethics committee, they have reported that they have got a formal ethical review approval from the IRB of University of North Carolina and WHO Research Ethics Committee as well. So next, coming to the eligibility criteria, the inclusion criteria included eligible participants, women in the reproductive age group who were attending routine cervical screening in Africa in these 5 countries. And they did not report any particular participant. They have reported participant level entry criteria, but they have not specifically given any details about data level entry criteria. And eligible participants were just recruited by convenience sampling. And they've also clearly mentioned the setting, location, and dates in which the study was done. The setting was in 5 different countries in Africa, and the study was done between March 17, 2022 to January 13, 2023. And the participants here were recruited by convenience sampling, as mentioned in the study. The exclusion criteria for the study they have reported is current pregnancy and those who have had a previous hysterectomy or removal of the cervix.
Not been ideal recruitment strategy.
A random recruitment.
It's difficult to randomly do. Prospective is correct. Otherwise, consecutive. Everybody who comes. So, consecutive recruitment should have been done.
Yes.
Not that easy, but that is right.
And they had also excluded participants who were previously under treatment for cervical or precancerous lesions of the cervix. And they had also excluded patients who did not have a proper visualization of the cervix because of inflammatory changes related to an acute infection. And coming to the sources of data, whether they were routinely collected or specifically collected for the purpose of the study, here all the data for the study was prospectively collected specifically for the purpose of the diagnostic accuracy study. And who undertook annotations for the data set? The AI-based test did not require any annotations or human input. It was an automated thing. Whereas the reference test was histopathological biopsy, which required annotation by expert local pathologist. And the study AI guidelines also requires the reporting study to explicitly mention the device that they have used to capture data and what algorithm they have used for capturing the data. This they have clearly mentioned in the study, saying that they have used Samsung A21 smartphones, and they had utilized the software called as AV app, which was developed by Global Health Labs. And this app was loaded into this mobile phone, and it did not require an internet connection. And it was able to give a result within a span of 1 minute. And once the results are given by the test, or the results are uploaded to an electronic study base, and it was uploaded to an online study software. And what was a study protocol, and did they have a specific algorithm? The healthcare worker uses this smartphone to take a photograph of the cervix, and the algorithm per se analyzes whether the photo is of reasonable quality, and if it is not, it asks the user to retake the photo. And once the quality of the image is satisfactory, the second algorithm analyzes the image of the cervix and reports whether the lesions are likely to be precancerous or not as a dichotomous outcome. So this is just a visual representation of how the pre-cancer screening is done with the AI-based test. First, we apply acetic acid using a speculum, and we see whether the VIA test is carried out, and we see whether it's positive or not. And the VIA test, whether it's positive or not, is entered into the software. And once this VIA test once the VIA test is done, the cervical image is captured using the Samsung A21 smartphone, and it is subjected to AI-based analysis, and it gives an instant result as to whether the test is positive or negative. And depending on further, it's further confirmed with the histopathological examination. And next, checking whether the index test was described in sufficient detail. Yes, they have described this test in sufficient detail to explain how the study was carried out. Again, it was the Samsung A21 smartphone loaded with this app, and the screening considers 3 parts. First was HPV DNA testing. The second part was VIA test and entering of the result of the VIA test into the smartphone app. And third part was taking the photograph of the cervix, which was subjected to analysis by the smartphone. And this data was subsequently transferred to an electronic study database using Wi-Fi. And how the index test was developed, this index test was developed by Global Health Labs, and it was first initially used in 2019. And was the study was validated? Yes, they have reported that they have used an internally validated study, and this is the first study which is externally evaluating the study in a target population. And have they given any specific cutoffs for test positivity or negativity? They have not specifically mentioned how the AI algorithm decided whether the cervix had a precancerous lesion or not per se. And they have also clearly mentioned the specified end user of the index test and the level of expertise required. The healthcare nurse providers from each facility, they were trained to use this AI-based software and data management tools prior to the launch of the study to carry over this test. And next, coming to the reference standard, did they describe the reference standard in detail? Here again, the study clearly defines the reference standard and how they proceeded with the reference standard. Those who had an acetowhite lesion on a VIA test were subsequently, they underwent a punch biopsy sample collected from the acetowhite area and another sample from a normal appearing area from the squamocolumnar junction. And if no acetowhite lesion was visualized, they still underwent a punch biopsy of the sample, but this was collected from 4 different quadrants of the transformation zone. The rationale was seemed fair enough because globally the accepted gold standard for cervical cancer diagnosis is a histopathological biopsy. And what is the rationale for describing test positivity cutoffs for the reference standard? Here they have explicitly mentioned the same. They have taken the reference standard to be positive if the on-site pathologist and the secondary pathologist who has analyzed the slide reported it to be a CIN2 plus lesion, or at least one pathologist should have reported it as a CIN2 lesion along with P16 staining on the immunohistochemistry being positive. If there was a discordance between the first and the second pathologist, they utilized a third pathologist and who was a tiebreaker. Or if there was a discrepancy, they utilized this P16 ISC testing. And if it was positive, they took it as a positive reference test. And who are all deemed as reference test negative? Those who had negative 3 pre-screening tests, which included HPV testing, BIA testing, as well as the AI-based automated testing. If all 3 were negative, they did not undergo a cervical biopsy, and they were taken as reference negative. And if the biopsy was deemed to be normal by the first pathologist, it was again taken as negative. And if 2 pathologists had opined that the lesion was less than CIN2, it was taken as negative. And if one pathologist had opined that it was not a less than CIN2 lesion and P16 staining was negative, they have again taken it as a reference negative.
So that there is one group of people who didn't actually have
Undergo a biopsy, sir.
That's a little.
Yes.
Would that have been because of ethical concern?
Unnecessarily subjecting them to a
But usually
basic
diagnostic test, everybody needs to have the reference standard. That's one small issue that you should point out.
yes, sir. Next, coming to whether the clinical information and reference standard results were available to the performers or readers of the index test. The reference standard test was not available to the performers of the readers of the index test, and it was done subsequently after the index test was done. And regarding the reference standard, when the reference standard test was done, the index test, which was the AI-based test, the reports were not available. But however, the pathologist here had access to the reports of the HPV DNA testing. That could be a possible source of bias, because if the pathologist had seen that it was HPV positive, the person might be more likely to report it as a CIN2 lesion or a precancerous lesion as compared to the person who's HPV DNA negative. So next, coming to the analysis part of the study, did the study report methods for estimating or comparing measures of diagnostic accuracy? The authors have reported the study in terms of sensitivity, specificity, positive and negative predictive values of the index test, which is the automated visual examination. And they've compared it with the reference standard, which is the histopathological biopsy. And what did they do about the indeterminate tests and the missing data of the test? For that, I'd like to go to the study profile. And here we could see they had recruited about 24,447 participants. And in them, about 1,516 of them had an inconclusive AI-based screening test. And this was about 6.2% of the enrolled participants in the study, and they were not included in the final analysis. And again, even among those who underwent the reference test, which is the histopathological biopsy, about 3,028 were excluded on the index test negative arm, and about 2,211 were excluded on the index test positive arm due to various reasons. Some reasons included those who did not have an indication for biopsy, like the ones who had triple negative. And some participants did not undergo consent for a biopsy, and some of them, biopsy was done, but there was no conclusive diagnosis reached based on the biopsy reports. And there were some other participants who were excluded because they had a type 3 transformative zone. It is a anatomical variation wherein the transformation zone is not clearly visible on the speculum examination, so the biopsy reports cannot be interpreted. So overall, there are about 27.6% of the eligible population were excluded from the analysis part of the study, which was quite significant. So did the study have any analysis of variability in diagnostic accuracy? And here we saw in the beginning of the study that they intended to do secondary and tertiary analysis as well. The secondary analysis, they had planned to do the index test as either VIA or the AI-based test being positive to be as index test. And tertiary analysis, they had planned to integrate HPV testing into the histopathological biopsy to be taken as a reference standard. And they have also reported in the final results of the study outcomes in terms of HIV positive and HIV negative, and based on the method in which they had done the VIA test, whether it was naked eye method or the digital cervicography method. But they have not previously stated prior to the start of the study. It was a sensitivity analysis. They have not done any performance error analysis or an algorithmic bias assessment in this study. So next, coming to sample size calculation. The sample size calculation appears to be taken based on the assumed bias sensitivity of, the AI-based test sensitivity of 88% and specificity of 83% from prior available data. They assumed a margin of error of 5% for sensitivity and 1% for specificity. The final calculated sample size as per them was 445. But when we tried to input the values of the study, the assumed sensitivity and specificity, and the prevalence of CIN2 lesion as expressed in the study, the sample size that we got was 222. They have not specifically mentioned how they reached 445 as the sample size in the study.
222 people with disease.
Yes, sir.
Disease, final disease.
Yes, sir.
Go back to their sample size.
It was double that number. Maybe two-sided.
We also would have put two-sided in this calculation. That's double higher. Decision, we have put 5%. This is two-sided calculation.
Yes, sir.
This is two-sided. Maybe like he says that they put 99% confidence interval. Okay.
And next, coming to the workflow of the study, around 25,114 participants were screened and 24,447 were enrolled in the study. And those who had an inconclusive test on the AI were excluded. And 17,000 were index test negative and around 5,610 was index test positive. And in those who did not undergo a cervical biopsy or in whom the cervical biopsy could not be interpreted, they were all excluded. And about 14,293 were included in the final analysis in the index test negative side, and 3,399 were included in the final analysis in the index test positive side. Around 190 of them had a CIN2 positive lesion in the index test negative side, and 286 of them had a CIN2 positive lesion on the index test positive side. So next, coming to the baseline characters of the study, they've reported the baseline characters in the study, and they've looked at the age group of the population, and they've also looked at the HIV status of the population. Here we could see that there was a quite higher incidence of HIV positive individuals recruited in the study, which was as high as 39.1% overall. Between countries,
54% in Zimbabwe and 52 in Malawi.
yes, sir. But we would not expect the same level of prevalence in our general screening settings. They have not looked at other risk factors for cervical carcinoma like multiple sexual partners or other aspects. They only looked at HIV status and the age group. HIV per se increases the risk of invasive cervical carcinoma. Sorry, sir. But I'm not specifically sure.
You can see when you do the subgroup.
And about 66.7% were index HPV negative and 31.5% were index HPV positive. And they did report the distribution of severity of disease in those with the target condition. They have not reported per se. They have only reported as being CIN2 plus or CIN less than CIN2. They have not mentioned how many of them were CIN3, how many of them had invasive carcinoma, and how many of them progressed to adenocarcinoma. And they have not specifically said the alternative diagnosis in those who did not have a precancerous lesion. They only reported it as being inconclusive. And have they reported the time interval between the index test and the reference test? Yes, there was a difference in terms of time duration from the index test and the reference test. So in one country, they had done it together simultaneously, whereas in another country, the difference was as long as 84 days. So we cannot be sure whether in that mean duration, whether the CIN2 could have progressed to another next stage or anything, and whether that could have influenced the results of the study. Yes. and whether the data set used in the study was representative of the target condition that we would expect in our intended use population. In the study, the prevalence of the CIN2 lesion was reported as 1.9%, whereas in multiple Indian studies, what we were able to see was estimated prevalence between 0.3 to 0.9%. Higher prevalence could be positive, probably because of the higher HIV positive status at baseline. And for external evaluation, they have not provided any validation or training data set in this study. And next, coming to the results of the study, did they provide a cross tabulation of the index test by results of the reference test? Yes, they have provided the same. And they have also given the precision and the 95% confidence intervals of the study. So this is the index test, which is the AI-based visual examination. And overall, they reported the sensitivity, specificity, positive predictive value, as well as the negative predictive value. And they also reported the specific similar parameters for the VIA test as well. So just a brief recap about the 2x2 table that we have been routinely seeing in all our CU sessions. And let's try to calculate the sensitivity and specificity of the study based on whatever they have reported. Sensitivity, as we all know, it's the ratio of true positives among those who have the disease, and specificity is the ratio of true negatives among those without the disease. And positive predictive value helps us to know among those who test positive, how likely are they to have the disease, and negative predictive value tells us if the test is negative, how likely are they to not have the disease. And we'll also be calculating the likelihood ratios as well. So I've just extracted the data available on that they've provided, and I've made a 2x2 table. And the one on the top is the reference standard, one on the left side is the index test. And I've put up the 2x2 table. Would anyone like to calculate the sensitivity and specificity of this study? The form. 60%, okay. And specificity, what did? Specificity is coming to around 80%. And next, the positive predictive value was 8.4%, and the negative predictive value was 98.7%. Would anyone like to calculate the likelihood ratio from the available values? The positive likelihood ratio is calculated by sensitivity by 1 minus specificity. A negative likelihood ratio is 1 minus sensitivity by specificity. Yes, positive likelihood ratio was 3. Negative likelihood ratio was 0.49 in this test. And similar calculations for the routine screening test that we are currently using, which is the visual inspection with acetic acid. The sensitivity of this study came to as low as 36% in this study, and the specificity was little higher as compared to the AI-based visual examination, which was 94.15%. The positive predictive value was 14%, and negative predictive value was 98%, with a positive likelihood ratio of 6 and negative likelihood ratio of 0.6. So coming back to a scenario, so Mrs. A, and we have two patients, Mrs. A and Mrs. B. Who do you think has a higher likelihood to have a cervical cancer? Is it Mrs. A or Mrs. B? What do you think? B is more likely to have. Okay. So based on the likelihood ratio, we'll try using the Fagan's nomogram and see what is the pre-test probability and what is the post-test probability after the utilizing the index test. So a study is said to be significant if it has a positive likelihood ratio of more than 10 or a negative likelihood ratio of less than 0.1 to be significant, whereas our study was nowhere close to that level. So this is the Fagan's nomogram, which we can use to assess the post-test probability of the participant having a precancerous lesion based on the likelihood ratio of the test. what do you think is patient A's likelihood of having cervical cancer? She's an asymptomatic female without any high risk sexual behavior, and she has come for a routine screening. She's young. 5. Sure. So I assumed it to be 2% in the study, and considering the positive likelihood ratio to be 3, even after using the positive likelihood ratio of 3, the post-test probability came to only 5%. And the same calculating the negative likelihood ratio, assuming a pretest probability of 2 with the likelihood ratio of 0.5%, the post-test probability came to 0.5%. So based on this, if the test is positive or negative, what do you think? Can we reliably say she has a cervical precancerous lesion, or can we entirely rule out a cervical precancerous lesion? What do you think? Not really. So if the test is positive, the post-test probability is still 5%. And anyway, we'll have to subject the patient to a histopathological examination for confirmation. And that test per se did not add much to the uh, likelihood of the patient having a precancerous lesion. Whereas here, the pretest probability was 2%. If the test had come negative, it reduced to about 0.5%. So maybe in this scenario, in a person with a very low probability of having the disease, and if the index test had come negative, maybe we can skip the histopathological examination for the patient. And next, coming to patient B, what do you think is her pretest probability of her having a precancerous cervical lesion? 50%. Any other answers? 30. Okay. So I had calculated it based on a probability of 70%. And assuming taking the likelihood ratio as 3, the post-test probability came as 90%. And considering the negative likelihood ratio of 0.5, the post-test probability of her having a precancerous lesion, if the test was negative, was still 50%. So based on this test, do you think if the test was positive or negative, will it change our management? Or will we subject everyone to a cervical biopsy? Yes. Yes. So if there is a pretest probability of 70%, obviously, even if the post-test probability came somewhere close by, we'd anyway need a histopathological confirmation for the study, and our study will not likely help in this scenario. And even if the test has come negative, the post-test probability still comes as high as 50%. So our study will not help to reliably rule out or rule in a disease. All of these participants who have a high pretest probability will anyway have to undergo the histopathological test. And next, coming to the ROC curve, the study had only a dichotomous outcome, so they couldn't calculate an ROC curve. The highest sensitivity was with HPV testing, which was as high as 90%, which was followed by the combined use of AI-based test and visual inspection with acetic acid, which was then followed by the AI-based test, and the lowest sensitivity was with the visual inspection with acetic acid. So did the study report any specific adverse events? In the study, they have not mentioned any specific adverse events due to performing of the index test or the reference test. But they did not consider factors like what if the index test had come positive, and what if the patient had become anxious about that further testing, or what if she would have become more anxious that she might have an underlying cancer. So all that things were not considered in this study. So next, coming to the study limitations. There are so many study limitations that we could point out. One was, like Sir had pointed out, one was the partial verification bias, because not all of the participants in the study had undergone the gold standard, which is the histopathological biopsy. And there is also significant exclusions. About 27.6% who were recruited were excluded due to various reasons, especially because of indeterminate results on the index and reference standard. And there is also possibility of a spectrum bias because they did not include the general population, and rather they had utilized participants who had themselves voluntarily come for a screening test. And the recruitment was also not done by consecutive sampling, and it was done by convenient sampling, which was a negative factor for the study. The HIV positivity rate was also quite high, and we would not expect that much of prevalence of HIV in our setup, in the screening setup. And we are not sure whether the availability of the HPV results to the pathologist, whether it could have influenced the reporting of the biopsy specimens as CIN2 and above or CIN2 or less. And other thing to consider is learning curve. The healthcare workers will be able to use this new AI-based platform, and how much of learning curve will be required. And they have explicitly mentioned in the study that this software works only on the Samsung A21 smartphone. And currently, that smartphone is not being produced any further. And every time we use a new smartphone, this app has to be installed, and it has to be the algorithm has to be specifically trained for that particular mobile phone, which adds to that. It makes it more tedious. And the company which had developed this app has also funded the study as well. And the company as per se has also been involved in the protocol management and as well as the reporting of the study as well, which could have been a source of bias. And whether any implications for practice, they have reported that they feel that using this AI-based test could increase the sensitivity of detecting pre-cancer lesions in low and middle income countries. I feel maybe in a participant who has a low pretest probability, it might be useful, but not in a person who has a high pretest probability of the disease. And in the secondary analysis, they have noted that using the combined sensitivity of both AI-based test and VIA improved the sensitivity of test as compared to the AI-based test alone. And they have not explicitly mentioned about the registration number or name of the registry that they've used, and where the full study protocol can be accessed. It's not provided in the study. The study has been funded by the same company which developed this test, and they have also been involved in data analysis and interpretation and drafting of the manuscript, which could be a source of bias. They have not specifically commented about any commercial interests in this study. And they have not provided the data sets or codes or outputs in any supplementary material in the study also. So would anyone like to calculate again, based on a pre-test probability of 50%, what would be the post-test probability of her patient having a cervical precancerous lesion? So here, if we consider the pre-test probability to be 50 and we consider the likelihood ratio to be 3, it still comes to around 70%, which again still doesn't really change our management. And again, considering the pre-test probability to be 50 and considering the likelihood ratio to be 0.5, we see that the post-test probability still remains as high as 30%. So again, in this scenario, it will not be much useful. So this is again the fact where they've again done a secondary analysis utilizing both VIA and AI-based test as the index test, and it showed to have a higher sensitivity as compared to the AI-based test alone. And even utilizing them as well yielded almost similar post-test probabilities. It did not change much. So in this, I'd like to conclude saying in participant A, maybe if the test was negative, I can skip the histopathological biopsy. Whereas in the participant B, I would not rely on this screening test. Even though if it comes positive or negative, I would still subject the patient to a histopathological biopsy for confirmation for precancerous lesion. I'd like to thank Tambu sir and Vignesh sir for helping me with the PPT.